Welcome to the Deep Dive. Today we're tackling a really significant area within wound care, arterial ulcers of the lower extremity.
And our main source for this exploration is the text, Wound Care Essentials, Practice Principles, specifically that chapter focusing right on these tricky wounds.
Right. So our goal for you, the listener, is to walk away with a clear, useful understanding. What are these ulcers? Why do they happen?
Yeah, how are they diagnosed and what are the current treatments? We want to give you the essentials, without getting totally bogged down in every single tiny detail.
Exactly. We've gone through this medical text pretty thoroughly to pull out the key stuff. And it's important context. These ulcers, they're a big deal, especially for older folks, and often point to underlying artery problems in the legs.
Definitely. Okay, so to really get it, we probably need to start with the basics, right? The plumbing, essentially, the arterial system itself.
Makes sense. Where does it all begin?
Well, it really starts with the descending aorta. And higher up, you've got branches like the intercostal and lumbar arteries. Now, they're not the main supply to the leg, but they can become important backup routes if there are blockages lower down.
Ah, collateral circulation, even way up there.
Exactly. Then you get down to the iliac arteries, common, internal, and external.
Okay.
The internal iliacs, they mostly feed the pelvic organs, but they also have connections like the gluteal branches that can offer another pathway to the leg. But the real main highway is the external iliac.
Right, and that becomes the femoral artery, the one in the groin.
That's the one. The common femoral artery. You can usually feel that pulse pretty easily there.
Yeah.
And then that common femoral splits, it divides into the superficial and the deep femoral arteries.
Okay, superficial and deep. Is one more important than the other?
Well, they both matter, but the deep femoral artery is often like a critical backup. It provides really important collateral flow if the superficial femoral artery gets blocked, which happens quite a lot, actually.
Gotcha, so like a built-in detour system.
Precisely. Then, moving down below the knee, it gets even more branched out. You've got the popliteal artery right behind the knee. That then splits into the anterior tibial artery and the tibioperoneal trunk.
Okay, slowing down a bit. Anterior tibial that goes down the front.
Correct. Down the front of the leg into the foot, and that's where you find the dorsalis pedis pulse, the one on top of the foot we check.
Right. And the other one, the tibioperoneal trunk.
Yeah, that trunk then quickly splits again into the peroneal artery and the posterior tibial artery. Both of those head down towards the ankle and foot area.
Wow, it really is like a complex road network down there.
It is, and these vessels continue into the foot. You have the dorsalis pedis, the plantar arch formed by branches, all connected by these, collateral pathways. Even the peroneal, which kind of ends above the ankle, sends branches down to help supply the sole.
And surgeons can actually work with all these tiny vessels now.
Yeah, it's pretty amazing. They can do bypasses to pretty much any of these named arteries, even the really distal ones in the foot.
Incredible. So it's not just a simple pipe carrying blood, is it? What's the artery wall actually like?
Good question. No, it's definitely not just a pipe. It has three distinct layers. There's the outer layer, the adventitia, that's for strength and support.
Good.
Then the middle layer, the media, that's got muscle and elastic fibers. Gives it strength, but also lets it contract or relax.
Controlling blood flow.
Exactly.
Yeah.
And then the inner lining, the intima, which is this smooth endothelial layer. What's interesting is that as you go further down the leg, especially in those tibial and peroneal arteries, the muscular component gets more prominent, allows for finer tuning of blood flow down there.
So these arteries are actively managing the flow. How do they keep blood flowing, even if there's some narrowing, some plaque?
Right, so they have this ability to widen, to vasodilate. They can compensate for some initial plaque buildup to keep the blood volume flowing pretty consistently. But there's a limit. Once that narrowing or stenosis hits about 50% of the artery's diameter, the artery can't really dilate anymore to compensate. Any further blockage after that point directly cuts down the flow.
And beyond the blockage, the artery might even narrow a bit.
Yeah, sometimes it adapts to the reduced flow coming through. It sort of constricts slightly downstream.
And it's not just the pipe size, right? The blood itself matters. Viscosity.
Oh, absolutely. Blood viscosity, how thick it is, makes a big difference to flow. The main thing determining that is the hematocrit, basically the percentage of red blood cells.
So more red cells, thicker blood.
Generally, yes. Things like dehydration or conditions like polycythemia, where you have too many red cells, can thicken the blood. That can cause problems almost like sludging in the tiny vessels, reducing perfusion. Even mild dehydration can be an issue, especially for older adults who already have some arterial disease.
I remember hearing about a drug, pentoxifylline.
Yeah.
Does that help with this? making blood less viscous or something?
The idea behind pentoxifylline was that it might make red blood cells more flexible, helping them squeeze through capillaries. But honestly, the clinical evidence showing it actually helps much with arterial disease or ulcer healing. It's pretty limited.
Ah, okay. Not a
Yeah.
game changer then.
Not really. Cilostazol, on the other hand, which helps stop platelets clumping and also widens arteries, that has shown some benefit in improving walking distance for people with claudication.
Interesting distinction. Okay, one last thing on flow dynamics. Skin versus muscle during exercise.
Yeah, that's a key difference. Muscles, with training, can get better at using oxygen and can actually increase their blood flow over time. That's why exercise programs can help people with claudication walk further eventually,
Okay.
but the skin doesn't really have that same ability to ramp up its blood supply just through exercise.
Okay, that makes sense. So, very complex system. Now, let's get to the main event. The ulcers themselves.
Mhm.
What exactly is an arterial ulcer?
Put simply, it's a wound that just can't heal because it's not getting enough oxygen-rich blood. It's starved. Essentially, that's ischemia.
And not enough oxygen delivery, maybe because of anemia too.
Anemia can definitely make it worse, yeah. Less oxygen carrying capacity in the blood. Often these ulcers get started by something small, like minor trauma, maybe bumping the leg or a small infection, but in a limb where the circulation is already bad.
So the underlying poor blood flow is the real problem.
It's the fundamental issue. And there's this other concept too, ischemic reperfusion injury.
Ischemic reperfusion, what's that?
It means that sometimes when you do restore blood flow to tissue that's been starved of oxygen for a while, the sudden rush of blood and oxygen can actually cause more damage initially. It's something we have to factor in when planning treatment.
Wow, okay. So fixing the flow isn't always straightforward.
Not always immediately beneficial in every way, but ultimately, and this is absolutely key, you usually have to improve the arterial inflow for these ulcers to have a real chance of healing. Injured tissue needs more fuel, more nutrients to repair itself, and without good blood supply, it just can't keep up. That's when you risk tissue death, or gangrene.
Okay, that paints a very clear picture. So how do clinicians figure out if an ulcer is arterial? What's the diagnostic process?
It always starts with a really thorough patient history and a careful physical exam. You need to know about allergies, all their medications, even their job. Could there be risks of trauma there?
Makes sense. And the risk factors we mentioned. There's that mnemonic.
Right, the ABCDES, it's super helpful. A is for A1C, that measure of long-term blood sugar control.
Crucial for diabetes.
Absolutely. B is blood pressure. C is cholesterol. D is diet and obesity. E is exercise, or lack thereof. And S, smoking. Hugely important.
So you cover all those.
Yes, and you also ask about any personal or family history of diabetes, heart disease, stroke, or any previous artery problems. It all builds the picture.
Okay, history gives context.
Yeah.
What about the physical exam? What signs are you looking for on the limb itself?
The skin inspection is vital. You might see skin that looks really taut, shiny, maybe thin and fragile. We call that atrophic.
Okay.
Color changes are a big clue. The limb might look pale, really white when you lift it up.
Pallor on elevation.
Exactly. And then when you lower it, it might turn this deep, dusky red color. That's dependent rubor.
Right.
You also look for hair loss on the lower leg, changes in the toenails. They might get thick, dull, though you have to be careful not to confuse that with, say, a fungal infection.
Good point. What about temperature?
Yes, definitely.
Yep.
The foot or lower leg with poor blood flow often feels cool or even cold compared to the other leg or higher up on the same leg. Those little handheld infrared thermometers are actually pretty useful for getting an objective measure of skin temperature. Can help spot inflammation or infection too.
And capillary refill, is that reliable?
Capillary refill time, pressing on the skin and seeing how fast the color returns, it's often checked. But the Wound Healing Society actually advises it's not the most reliable sign on its own for judging deep tissue perfusion.
So part of the picture, but not the whole story.
Exactly. You look at it, sure, but in context with everything else, normal is usually under 2 seconds.
Okay, and pulses. Checking the pulse has got to be key.
Oh, absolutely essential. You feel for the femoral pulse in the groin, the popliteal behind the knee, the dorsalis pedis on top of the foot, and the posterior tibial behind the ankle bone.
And how do you describe them? I've seen number scales.
Yeah, the number scales can be a bit subjective, honestly. It's often more helpful just to describe them. Are they present or absent? Are they weak? Are they strong? Maybe even bounding? That's usually clearer.
And they can change with activity.
That's a really important point. Someone might have pulses you can feel when they're resting, but after they walk a bit, the pulses disappear. That's a strong sign of significant blockage higher up.
Interesting. You mentioned the popliteal pulse behind the knee. Anything special about that one?
Well, if it feels really strong, like bounding, it could be a sign of a popliteal artery aneurysm, a bulge in the artery wall.
And that's bad because...
Because those aneurysms can throw off little clots, emboli, that travel down and block smaller arteries in the foot. That can cause blue toe syndrome, sudden pain and discoloration in a toe because its blood supply got cut off.
Ouch. Okay. And we can't forget nerve issues, right? Neuropathy.
Critically important, especially for patients with diabetes. Peripheral neuropathy means they lose protective sensation. They might not feel pain from an injury or the ulcer itself, so they might not seek help until it's quite advanced.
So the usual pain signals are missing.
Right. We use the mnemonic SAM, sometimes sensory, autonomic, motor, to think about the different parts of neuropathy. And the Semmes-Weinstein monofilament test, using that little filament to check for light touch sensation, is a key way to objectively assess for that sensory loss.
Okay, so history and physical exam give strong clues. What about the specific symptoms, like pain? What does arterial pain feel like?
Well, the classic symptom is claudication. That's a cramping or aching pain, usually in the calf, but could be thigh or buttock, that comes on predictably with walking a certain distance.
And it goes away with rest.
Yes, that's the key characteristic. Stops fairly quickly when they stop walking. We try to quantify it. How far can they walk before it starts? That's the initial distance. And how far before they have to stop? That's the absolute distance. Shorter distances usually mean worse disease. And we also note how long it takes for the pain to go away after stopping.
Okay, that's claudication. But then there's a worse pain.
Yeah.
Rest pain.
Yes, rest pain is much more serious. It signals critical limb ischemia, really severe lack of blood flow. Patients often describe it as a sharp burning pain, often worst at night, typically in the toes or the front part of the foot.
And they find ways to relieve it.
Often they'll hang their foot over the side of the bed or even get up and walk around for a minute. Using gravity to get a little more blood down there helps temporarily. It's the opposite of venous pain, where elevating the leg feels better. With arterial rest pain, elevation usually makes it worse.
That's a really important distinction. What if the patient also has neuropathy? Does that change the pain?
It absolutely can. If they have significant sensory loss, they might not feel that typical ischemic claudication or rest pain, even with severe disease.
So danger lurking without the usual warning sign.
Exactly. Or they might have different kinds of pain, neuropathic pain, like burning, shooting, stabbing feelings, or extreme sensitivity where even light touch hurts. That's from the nerve damage itself, not directly from the ischemia, although the two often go together in diabetes. And their ulcers might be in different places too, often under calluses on the bottom of the foot due to pressure they don't feel.
Okay. Beyond pain, what other physical signs scream arterial problem?
Well, the most severe sign is gangrene. That's actual tissue death from lack of blood. It often changes color, starts pale, then gets mottled blue or gray, then purple, eventually black and hard.
Is it painful?
The dead tissue itself isn't usually because the nerves are dead too, but the area around it, the border between dead and dying tissue, can be extremely painful.
Graham, any other signs?
You might see small, pinpoint spots of discoloration on the tips of the toes, or near the nails, tiny infarcts from microemboli, or just severe lack of flow. Or sometimes you find these little erosions or ulcers right between the toes, often started or worsened by shoes rubbing.
And the ulcers themselves, what do they typically look like?
Arterial ulcers often have this very distinct look. The borders are sharp, well-defined, almost like they were punched out.
Okay.
The base of the ulcer tends to look pale, maybe grayish or yellowish, and it's usually dry, not weepy. You might even see deeper things like tendons or bone if it's severe.
And the skin around it.
The surrounding skin might be pale, or, like we said, show that dusky red dependent rubor if the leg is hanging down. And the skin overall on that limb might look thin, shiny, fragile. Elevating the foot makes it look even paler. Dependency brings out the redness.
Got it. And one last physical sign, checking blood pressure.
Yes, measuring blood pressure is fundamental. Even if lower extremity pressures aren't routine everywhere, you should always check the pressure in both arms first.
Why both arms?
To make sure there isn't a big difference between them, which could indicate a blockage higher up, like in the subclavian artery. You use the higher of the two arm pressures as your baseline for calculating the ankle brachial pressure index, the ABPI.
The ABPI. Okay, so we've got the history, the exam findings. Now we need objective tests. That's where the vascular lab comes in.
Exactly. Vascular lab studies are crucial. They confirm the diagnosis, help pinpoint where the blockages are and how bad they are, and can even give us an idea about the chances of an ulcer healing.
And there are different types of tests, direct and indirect.
Broadly, yes. Direct tests actually look at the blood vessels, like an ultrasound scan showing the artery wall and flow. Indirect tests measure the effects of the disease downstream, like changes in pressure or blood flow volume.
Okay. What's a common indirect test?
The handheld Doppler is probably the most common starting point. It's that little probe that uses ultrasound waves.
The one that makes the whooshing sounds?
That's the one. It listens to the blood flow. But you can also use it with a blood pressure cuff to measure the systolic pressure at different points, especially the ankle.
Which brings us back to the ABPI. How is that calculated again, and what do the numbers mean?
Right. You take the highest systolic pressure you measured at the ankle, either from the dorsalis pectus or the posterior tibial artery, and you divide it by the highest systolic pressure you measured in the arms.
Okay. Ankle pressure divided by arm pressure.
Correct. A normal ABPI is generally between 0.9 and 1.3. If it's below 0.9, that usually indicates some peripheral arterial disease.
And lower numbers mean worse disease.
Typically, yes. Someone with claudication might have an ABPI between, say, 0.5 and 0.9. If they have rest pain or an ulcer, the ABPI is often below 0.5. Interestingly, for those with really critical ischemia, the ABPI might not drop much more with exercise because their arteries down there are already wide open, trying desperately to get blood through even at rest.
Makes sense. But you mentioned the ABPI isn't always reliable.
That's a really important caveat. In people with diabetes, and sometimes in older individuals or those with kidney disease, the arteries in the lower leg can become calcified, really stiff.
Like pipes turning into concrete?
Kind of, yeah. So the blood pressure cuff can't compress them properly. This gives you a falsely high ABPI reading, sometimes way over 1.3, even when the actual blood flow is terrible.
So a high number could be misleadingly good.
Exactly. In those cases, the ADPI isn't helpful, and we have to rely on other tests, like measuring the pressure in the toes T pressures or using things like transcutaneous oxygen measurements, TCPO2, to see how much oxygen is actually getting to the skin.
Okay, what about segmental pressures? What do they add?
Segmental pressures involve putting cuffs at different levels on the leg, high thigh, above knee, below knee, calf, and ankle, and measuring the pressure at each level.
Looking for pressure drops.
Precisely. If you see a significant drop in pressure, usually 20 millimeters of mercury or more between one segment and the next one down, that helps you locate where the significant blockage likely is.
Narrows down the location. And toe pressures, you mentioned, they're better sometimes.
Yeah, especially when those lower leg arteries are calcified. The little arteries in the toes usually don't get that same medial calcification, so measuring pressure there gives a more accurate picture of the perfusion right at the end of the limb.
And is there a target number for healing?
Generally, a toe pressure of 55 millimeter Hg or higher suggests blood flow is probably good enough for healing. Below 30 millimeter Hg, healing is much less likely without improving the flow first.
Okay. And then the really detailed picture comes from an arteriogram.
Right. An arteriogram is an invasive test. They inject contrast dye directly into the arteries and take X-ray images. It gives a very detailed map of the blockages.
But you don't do that on everyone.
No, definitely not. It's usually reserved for when you're seriously considering an intervention like surgery or angioplasty, and the surgeon or interventionalist needs that detailed roadmap to plan the procedure. If the patient isn't a candidate for intervention or doesn't want it, there's usually no need for an arteriogram.
Got it. Okay, so we understand the problem, how it's diagnosed.
Yep.
Let's talk treatment. What's the overall philosophy?
The guiding principle is often summed up as preparing the wound bed, but that involves several layers. First, you must address the underlying cause, the poor blood flow.
Makes sense.
Second, you have to consider the patient's overall situation, their pain, their quality of life, their goals. And third, you provide the right local wound care. But that care changes depending on whether the wound is considered healable, maintenance, or non-healable.
Healable, maintenance, non-healable. Can you break those down?
Sure. Healable means, essentially, if we can fix the blood flow and manage the wound properly, we expect it to close. Maintenance might be a wound that could heal, but maybe it's slow or other health issues are getting in the way. So the goal is more about preventing worsening. Non-healable usually means the ischemia is so severe and maybe can't be fixed that the wound realistically isn't going to close, so the goals shift to comfort and preventing infection.
And step one for a potentially healable wound is often getting a vascular specialist involved.
Absolutely critical. Early referral to vascular surgery or maybe interventional radiology or cardiology is key to see if blood flow can be improved. Bypass surgery, stents, angioplasty, they explore those options.
Okay, now, local wound care. Let's start with healable wounds. What's the approach there? Debridement.
Yes. For healable wounds, getting rid of any dead or unhealthy tissue, that slough or necrotic stuff, is usually important. It's called debridement. Cleans up the wound bed so healthy tissue can grow.
And how is that done?
Several ways. Sharp debridement using scalpels or scissors is common. There's also mechanical debridement, like using specific dressings, though older methods like wet to dry are less favored now. Enzymatic debridement uses special ointments. And autolytic debridement uses dressings that keep the wound moist, letting the body's own enzymes do the work.
What about maintenance wounds? Still debride.
Maybe more conservatively. Focus might be more on just keeping the surface clean, managing moisture, keeping bacteria in check, rather than aggressive tissue removal.
And for the non-healable ones, where healing isn't really expected.
Yeah, the goal changes. If there's dry, dead tissue like a black eschar and the blood flow is poor, you often don't debride it aggressively. The aim is often to keep it dry and stable, almost like a natural barrier.
So you might use drying agents.
Sometimes antiseptics like povidone iodine or chlorhexidine might be used carefully to reduce surface bacteria and help keep things dry, but you have to be cautious. Some antiseptics can be toxic to healing cells if used improperly or for too long. PHMB is another antiseptic sometimes used, considered potentially less toxic in some contexts. Things like Dawkins solution, though, are generally avoided now.
Infection is always a risk. How do you manage that with arterial ulcers?
Right, you have to distinguish between just bacteria being present, colonization, and actual infection, where the bacteria are causing harm and delaying healing.
How can you tell the difference?
Clinicians look for signs. The no-dabies mnemonic helps for superficial signs. Non-healing, exudate increase, red friable tissue, debris, smell. And stonies for deeper signs, size bigger, temperature increase. O, meaning probing to bone. New breakdown, exudate, erythema, smell.
Okay. Do swabs help?
Surface swabs tell you what bacteria are there, but not necessarily if they're causing an infection or how deep it goes. And they often miss biofilm, those slimy bacterial communities. So swabs are just one piece of information.
So how do you treat infection if you suspect it?
If it's a healable wound and looks critically colonized or superficially infected, topical antimicrobials might be used, things like silver dressings, cadexomer iodine, or those special foams with PHMB and dyes.
Okay.
For non-healable wounds where you just want to reduce surface bacteria, maybe short-term antiseptics like povidone iodine. But if you suspect a deep infection spreading into tissue or bone, or if the patient is systemically unwell, then you need systemic antibiotics taken by mouth or IV.
And figuring out if the bone is infected, osteomyelitis.
That can be tricky, especially with diabetes. Plain x-rays might not show it early on. Bone scans can be sensitive but not very specific. MRI is often the best imaging test for suspected osteomyelitis, but access and cost can be issues.
What about just cleaning the wound? Any special rules?
Yeah, gentle cleansing is key. You want to remove loose debris and exudate, but not damage fragile new tissue or the surrounding skin. Normal saline or even clean tap water are usually fine.
What about pressure? Like squirting the saline?
You want enough pressure to clean, but not so much that you damage tissue or force bacteria deeper. Somewhere in the 4 to 15 psi range is usually recommended. Whirlpool baths, though, are generally a no for arterial ulcers. Risk of infection can make swelling worse.
Good to know. And dressings. Any pitfalls there?
The big one is fragile skin. Because of the poor blood supply, the skin around an arterial ulcer is often thin, dry, and tears easily.
Yeah.
So you have to be really careful with tape or any adhesive dressings.
So what's the alternative?
Non-adhesive options are often better. Soft gauze rolls, tubular netting, maybe silicone-based adhesives, which are gentler on removal. If you absolutely need an adhesive, you just want to avoid causing more skin damage.
Makes sense. Okay, so general principles covered. Let's get specific. The number one goal you said is boosting blood supply.
Absolutely. Without adequate blood flow, nothing else works long-term for healing.
Are there simple things patients can do, like positioning?
Positioning can help a little. Keeping the leg dependent below the heart uses gravity to help blood flow down. But you need caution with things like foot cradles, especially if there's neuropathy, because the patient might not feel pressure points causing new problems.
Right. And the rule about debridement, worth repeating.
Definitely. Do not perform sharp debridement on dry, stable necrotic tissue if the underlying blood supply is severely compromised and can't be fixed. You risk creating a bigger wound that can't heal and might get infected.
Okay, so keep dry wounds dry if the flow is bad.
Right, let that dry eschar form a natural barrier.
But use moist wound healing if the flow is good or has been restored.
Exactly. If there's enough blood supply for healing, then moist wound healing principles apply. Use dressings like hydrocolloids, films, foams, maybe moist saline gauze, whatever. Maintains a moist environment to help cells migrate and tissue form. And always protect that surrounding skin from getting waterlogged.
Got it. But the real game changer is often restoring the flow itself. Arterial reconstruction.
That's usually the definitive treatment for healable ulcers caused by significant blockages. Surgical bypass grafts or endovascular procedures like angioplasty or stenting. This usually happens after the non-invasive tests and maybe an arteriogram to plan the approach.
When does surgery become the likely option?
Generally, if the claudication is disabling, if there's rest pain, if an ulcer just won't heal despite good local care, or if there's spreading gangrene or infection threatening the limb.
And the options are bypass or endovascular.
Those are the main categories. Bypass surgery uses a graft, either the patient's own vein, autologous, which is usually preferred, or a synthetic tube, prosthetic, to route blood around the blockage.
And endovascular.
That's done from inside the artery, usually via catheters. Angioplasty uses a balloon to push the blockage open, often followed by placing a stent, like a little mesh scaffold, to keep it open. There are also devices for atherectomy, sort of shaving out the plaque, and laser techniques. Drug-eluting stents, which release medication to prevent re-narrowing, are becoming more common too.
You mentioned a study, the Basel trial. What did that tell us about bypass versus angioplasty?
Right, Basel was a major trial comparing bypass surgery to balloon angioplasty for severe limb ischemia. It found that over the long term, particularly beyond 2 years, bypass surgery seemed to lead to better amputation-free survival.
So surgery had an edge long term.
It did in that trial, especially when the patient's own vein was used for the bypass graft that gave the best long-term results. But it's important to remember Basel was done before some of the newer, more advanced endovascular techniques were widely available. Still, it highlights the potential durability of vein bypasses.
Okay. Where are these bypasses typically done? What are the main zones?
You can think of 3 main areas. Aortoiliac, dealing with blockages high up in the aorta or iliac arteries in the abdomen pelvis. Femoropopliteal, tackling blockages in the thigh, femoral, down to the knee area, popliteal. And distal bypasses for disease below the knee, going to the tibial or peroneal arteries.
And surgeons usually try to fix the highest blockage first, the inflow.
That's the general principle, yeah. Restore good flow into the leg first. Sometimes fixing a bad aortoiliac blockage is enough to improve things downstream, even if there's still some femoropopliteal disease. They don't always jump to doing bypasses at both levels simultaneously unless absolutely necessary.
What about just the angioplasty and stenting route? When is that preferred?
It's become a really important option, especially for aortoiliac disease. For shorter, less complex blockages there, angioplasty with stenting has often replaced big open surgeries like aorta bifemoral bypass.
And below the groin and inguinal.
Historically, angioplasty results weren't as durable long-term compared to bypass surgery, especially for longer blockages below the groin. But the technology keeps improving: better wires, balloons, drug-eluting stents. So it's increasingly used, especially for patients who are higher risk for open surgery. There are guidelines, like the TAS-E2 classification, that help decide if endovascular is a reasonable first choice based on how complex the blockage looks.
For bypasses in the thigh, the FemPop bypass, does the graft material matter?
It does. For bypasses ending above the knee, synthetic grafts and vein grafts have somewhat similar results initially, though vein is often still better long-term. But for bypasses going below the knee, using the patient's own vein is strongly preferred. It just lasts much longer than synthetic grafts in that position.
And those really distal bypasses, down to the calf or foot arteries?
For those, you pretty much always need to use the patient's own vein, usually the saphenous vein taken from the leg. These are complex operations, usually done for critical limb ischemia, trying to get blood flow right down to the foot to save it from amputation.
What if someone has blockages at multiple levels? How do you decide what to fix?
It's a tailored approach. You look at their symptoms, where the worst blockages are, their overall health. Like we said, fix inflow first is a key principle. Sometimes it might involve a staged approach, fixing one level, then seeing how they do, or even a hybrid procedure combining some open surgery with an endovascular technique.
Okay. And what about dealing with the dead tissue, the gangrene itself?
Well, alongside trying to get the blood flow back, if there's clearly dead, demarcated tissue, it usually needs to be removed, debrided back to healthy, bleeding tissue. This reduces infection risk and allows healing if the revascularization works.
What if it's just dry gangrene?
Sometimes, if it's stable, dry gangrene and blood flow is restored, you might actually let it demarcate and separate on its own autoamputation. Or if it's just a toe or a small area, after revascularization, they might do a small, formal amputation and close the skin surgically to get faster healing.
And medications, what's the role there?
Medical management is supportive but vital. It's about managing those ABCDES risk factors aggressively. Antiplatelet drugs like aspirin or clopidogrel are standard to help prevent clots. Cilostazol can help claudication symptoms, as we mentioned, but not for heart failure patients. And again, pentoxifylline, the evidence just isn't there for it helping arterial ulcer healing.
Right. So it's a whole package. Fix the flow, care for the wound, manage the risks. How do you even track if these ulcers are getting better? They can heal slowly.
Yeah, measuring healing can be tricky. There isn't one perfect method. People might track the percentage of wounds that fully close, or measure the change in the wound's surface area over time, maybe using tracings or digital photos and software, or just measure the perimeter.
Is there a benchmark for good progress?
A common rule of thumb is looking for about a 20% to 40% reduction in the ulcer size within the first 4 weeks of good treatment. If you're seeing that, it's generally a positive sign that things are heading in the right direction.
And if it's not healing, despite everything, or the damage is too great?
That's when the really difficult conversations about amputation might have to happen. If the limb isn't salvageable, if the pain is uncontrollable, if the risk of keeping the limb outweighs the benefits or severely impacts quality of life, amputation might become the necessary option.
Tough decisions.
Okay.
Which makes patient education incredibly important throughout this whole process.
Absolutely vital. Patients have to understand what's going on, why they have the ulcer, what the treatment plan is, and what they need to do.
Like managing those risk factors.
Yes. Hammering home the importance of smoking cessation, that's number one.
Yeah.
Controlling diabetes, managing blood pressure and cholesterol, eating well, trying to maintain a healthy weight, appropriate exercise. It's all part of it.
What specific things should patients be taught to look out for or do?
They need to know how to check their pulses if possible, or recognize signs that a bypass graft might be failing. Know the warning signs of worsening ischemia. Understand they absolutely cannot use nicotine in any form. Get guidance on safe exercise. Strict glucose control if diabetic. Take their blood pressure and cholesterol meds. Meticulous foot care, checking feet daily. Proper nail care, appropriate footwear. And, of course, how to care for their specific ulcer as instructed.
That ABCDES mnemonic seems like a good framework for patients too.
Definitely. It covers the key modifiable risks they need to focus on. Smoking cessation just can't be emphasized enough.
The chapter included a short case study, Mr. WG. Can you summarize that quickly? What did it illustrate?
Yeah, Mr. WG was an older gentleman, had a non-healing arterial foot ulcer, but also had lots of other serious health problems that made him a really poor candidate for major vascular surgery.
So revascularization wasn't really an option.
Not easily or safely, no. So the team took a different approach. They used hyperbaric oxygen therapy, breathing pure oxygen in a pressurized chamber, combined with regular, careful surgical debridement of the ulcer.
And did it work?
Surprisingly well, actually. The ulcer completely healed, and his quality of life improved significantly, even though he sadly passed away about a year later from his heart problems.
So what's the takeaway from this case?
It shows that even when the standard revascularization options are off the table, sometimes thinking outside the box, using adjunctive therapies like hyperbaric oxygen and combining them with meticulous wound care, can still lead to healing and improved well-being, even in really complex patients. It highlights the need for individualized care.
That's a really powerful example. Okay, to wrap up our deep dive today on arterial ulcers, what are the absolute must-remember points for our listeners?
I'd say 3 main things. 1, arterial ulcers happen because of poor blood flow, period. That's the root cause. 2, diagnosis involves putting together the whole picture history, a careful physical exam looking for those specific signs, and objective vascular testing like the ABPI or toe pressures. 3, treatment hinges on improving blood flow whenever possible, combined with smart, tailored local wound care and aggressive management of all those cardiovascular risk factors.
Excellent summary. And to you, our listener, well done for sticking with us through some pretty detailed medical territory. Now, for a final thought to leave you with. We know risk factors like diabetes and obesity are increasing. So, thinking ahead, how might advancements in early detection of arterial disease, combined with perhaps even less invasive ways to restore blood flow, change the game for preventing and treating these ulcers in the future? Something to ponder.
Definitely food for thought.
As always, we encourage you to check out the source material, Wound Care Essentials, if you want to go even deeper, or talk to your own healthcare provider for personalized advice. Thanks for joining us on the Deep Dive.